Hi, everybody. Welcome to today's webinar, Deconstructing Candida, a root cause approach to addressing yeast overgrowth, brought to you by Diagnostic Solutions Laboratory and presented by Dr. Amy Rolfsen. Welcome, Dr. Rolfsen.
Thank you, Heather, for the introduction, and thank you everyone for being here. It means a lot to us that you're taking time out of your day to learn about our lab and learn about Candida. I'm going to make this very clinically applicable today. So like Heather said, I'm Dr. Amy Rolfsen. I'm a naturopathic doctor. I'm part of the medical education team here at Diagnostic Solutions Lab. And that means that when you have a test, when you have a GI map or another test, I'm part of the team that you might talk to when you call in for your complimentary consult. So we'll help you out with your test, interpreting your results. And if something like Candida comes up, we can help guide you. So today we are going to talk about Candida, a super fascinating organism that I think is misunderstood. We treat a lot of Candida in our functional practices. What I'm going to talk about is not the invasive Candidiasis, the serious medical condition. We're going to be talking about Candida gut overgrowth. So that's a big distinction there. So Candidiasis, invasive or systemic Candidiasis, is not the same as our superficial gut overgrowth of fungi. So let's get started. We will have time for Q&A at the end. And I'm going to go through one case today. So I'll make it very treatment heavy, but first I want to talk about all the weird things about Candida, because the more you know about an organism, the more you can target your treatment, either natural or pharmaceutical, to get rid of that organism, if getting rid of the organism is your goal. There we go. Okay. So just a tiny bit about Candida. There is a ton to know. There are a lot of metabolic byproducts and toxins and things like that. I'm not going into depth into those because I could talk about that all day. So sparing you those details. A little bit about it. It is a eukaryote. It's a fungus. It is perfectly adapted to live in the human body. So what is noteworthy and really interesting about Candida is that it is hugely flexible in its metabolism in the niches it can inhabit. So it can really live anywhere. It can change its food sources based on what's available. So if carbohydrates, which Candida obviously loves carbohydrates, if they're not available, it can take carbon from ethanol. It can feed off of nitrogen. We'll talk about that on a future slide there, but it can really shift to more acidic conditions, less acidic, more oxygen, less oxygen, and it will actually act differently in all those different niches. So a very dynamic organism. It has a double cell wall, so that means that it's got the ability to have things like efflux pumps. It can get a little bit more treatment resistance with that double cell wall because it can take in your antifungals, your antimicrobials, it can assess them and decide to pump them right back out if it wants to. It's got that chance to deactivate things with enzymes and control its inner environment just that little bit more. It has a lot of virulence factors, and these are basically nasty things that Candida can do to make the human host the perfect environment for itself. So I'll talk about those on a separate slide as well. And then the different forms of Candida, you can have it in its planktonic or single cell stage, less active, just basically a fungus. You can have it in its biofilm forming phase where it is working amongst itself and usually quite a few other organisms. It works very well with other bacteria to create an environment that they both thrive or they all thrive. And then it can be in its hyphal form, and this is more invasive form where it grows these extensions that can actually invade the epithelial layer. And again, I'll talk about that in a future slide. Super interesting stuff. So very briefly, that's what you want to know about Candida to start. Now, symptoms in your practice. The symptoms of Candida can really look like anything, and that can be challenging. So we do hear a lot in our functional practices of overtreatment of Candida, like, oh, that sounds like Candida, or that sounds like SIBO. Basically, the symptoms are very overlapping. There's a lot of overlap between symptoms, and testing is really important for Candida. So you'll see your gas and bloating, abdominal pain, you may see constipation or diarrhea, or neither, but it's very common to see gas, bloating, and abdominal pain. You may see reflux. It can be in the upper GI. It can actually coexist and work with H. pylori and cause some reflux. Indigestion is very, very common. And then food sensitivities or intolerances, increasing food sensitivities can also be from Candida because it can affect your digestion and absorption of nutrients and your ability to digest those antigenic food proteins. So moving on to the systemic or the non-GI symptoms, you'll see a ton here. And a lot of these are from the metabolic products of Candida. You'll see lots of sugar cravings in your patients, carb cravings, brain fog. So Candida, if you have enough of it, can actually rarely result in autobrewery syndrome, where you actually produce ethanol from the carbohydrates that you're consuming, or sorry, the Candida produces the ethanol, and it can actually convert that ethanol to acetaldehyde, which is one of the toxins that Candida can produce and that can come from drinking too much alcohol that makes you feel hungover. So you can feel that, just that nasty, tired, fatigued, and just not clear feeling when Candida is present. And you can actually produce your own ethanol. You can have weight concerns, either difficulty losing weight, weight gain, difficulty gaining weight. You'll see skin stuff very frequently with Candida, kind of a red, hot skin. Eczema is very common. And then recurrent vaginal yeast infections, often you'll see recurrent UTIs as well, joint and muscle pain, and then your mood stuff. So Candida can interact with our neurotransmitters. So GABA can increase our levels of Candida. I won't get deeply into this. Candida can produce serotonin. It can kind of augment your histamine production and affect your clearance. And so there are a lot of ways that Candida can affect your mood. It can also lead to neural inflammation. So lots to dig into there in the future, but for now, I will just say it can affect mood. So more serious conditions associated, so you can get your invasive candidiasis and candidemia, which have a very high mortality rate. That's going to be in your immune compromised patients, usually hospitalized. So we won't see a lot of these in our functional practices, but IBD, both Crohn's and colitis, can be associated with Candida. Airway allergies can be exacerbated by a Candida infection or overgrowth. You'll see autoimmunity because it does push that Th17 pathway. Celiac disease. And you can rarely end up with gastric and hepatocellular carcinoma from Candida and its byproducts. And then fatty liver disease, because it can produce ethanol, it's actually associated with alcohol-associated fatty liver disease and alcohol-associated liver disease. So risk factors in your patients that may lead to Candida overgrowth: immune compromise, the use of antibiotics, or really any change to the normal flora in your gut or your microbiome. Other medications beside antibiotics, so oral contraceptives, your proton pump inhibitors, even your NSAIDs are going to affect Candida levels. Damage to the mucosal barrier can cause Candida to overgrow. High carb diet, you've got your digestive insufficiency, so leaving nutrients on the table that you're not digesting yourself and absorbing yourself will lead to overgrowth of many things, including Candida. Alcohol consumption, e-cigarettes actually greatly increase Candida in the oral cavity. And then motility disorders, including gastroparesis. So lots and lots of risk factors there. Oh, and heavy metals, missed that one. So yeah, lots of risk factors in your practice that can lead people to get Candida, lots of symptoms that can come from Candida. You will see this a lot in your practice. And when you treat it, people will feel much better. And sometimes they'll feel worse before they feel better, as with a lot of our organisms that can produce endotoxins. So the virulence of Candida, it's got a lot of factors that allow it to survive in the human host and overcome things like antimicrobials, antifungals, competitive inhibition from other organisms. So it is finely tuned to the human body. It can adjust its needs based on what is available. So it is a chameleon organism and very cool. So it's got all those morphological variations I talked about before. Within those variations, you've got different things like opaque cells and white cells, and then the gut-specific cells. So you'll see a lot of changes depending where it is. It will act differently. It will be more or less invasive depending on the environment. Metabolic flexibility, as I've talked about, this does lead to Candida virulence because say you're putting somebody on a low-carb diet, but they're still drinking alcohol. They can take the carbon from that alcohol. They can take proteins and survive off of protein. So protein has been shown to inhibit Candida growth, but sometimes it can actually feed on that protein. It can feed on your minerals and metals. It is a biofilm producer, so this allows it to evade the immune system. It allows it to work in concert with other organisms. A lot of bacteria work in that multi-organism biofilm, and it will have a natural antifungal effect in that it's a physical barrier for the antifungals. Adhesion is a big part of its virulence because it can stick onto your cells, create that biofilm, hang on, and in some cases invade your cells. So if we can block biofilm, we can block adhesion. Those can be aspects of treatment that you can augment. Host invasion, I'll talk about in a future slide, but that's the ability to get through that epithelial layer in the gut into the body. It's got things like hydrolases and proteases that can break down tight junctions, can break down all sorts of different things, immune cells, things like that. And then it's got the hyphae, which is one of its morphological forms, but those can directly penetrate the epithelial cells and kind of dig in and cause that longer lasting, more invasive Candida infection. So a little bit about Candida physiology, just very briefly, definitely not everything to know, but its niche, its preferred niche, although it can live anywhere, would be the upper mid GI tract, which would kind of be your esophagus, your stomach, your small intestine. And then in the rest of the body, absolutely can live, but we're talking gut specific today. It will be right near or within the mucosal layer if it has a choice. And then food sources. We talked about these before, so nucleic acids even, it can feed off of those. So it can really be flexible with its food sources. And I'll talk about the Candida diet further on in the presentation, but I think given its metabolic flexibility, it isn't that rational to go hardcore with the diet because it can really survive on anything. We're not going to starve our patients in order to starve the Candida. So you do, in my opinion, clinically need those antimicrobials to make a difference. So co-infections are really, really common with Candida. Often it is Candida that is surviving in an environment that has a digestive insufficiency, and so the Candida is able to survive, and so are other organisms. It might not be a direct mutualistic relationship, just that when Candida can grow, so can other things. But then Candida can also work in these polymicrobial biofilms, especially with things like staph, with strep, with Pseudomonas. So these organisms, these four, come up a lot in the research. H. pylori, the next slide is all on H. pylori and Candida because they work really, really well together. But strep in the oral cavity, and then Enterococcus and Candida have a strong, strong interrelationship where they support each other. So when you see high H. pylori or high Enterococcus and high Candida, you know that you might want to address all of them at the same time, and you likely want to address biofilm. So Candida and H. pylori, it goes much deeper than what I'm going to get into, but they've got this great mutualistic relationship, great for them, not so great for us. A lot of symptom overlap. So you may see somebody with upper GI, gas and bloating. Is it Candida? Is it H. pylori? They've got ulcerations, probably at least somewhat H. pylori, but Candida can actually make H. pylori ulcerations worse. Candida can contribute to reflux. All the H. pylori symptoms basically could be explained by Candida. So if you see a very low level H. pylori and you think, I thought for sure this patient had H. pylori, look for Candida. Maybe that's the cause of the symptoms. Maybe they're working together. Maybe that low level H. pylori is significant. So Candida thrives in the environment that H. pylori sets up. That low acid environment that's very, very common with H. pylori overgrowth will favor Candida. And then H. pylori, more to it than this, but H. pylori can exist within Candida. It creates these vacuoles because Candida is actually a lot more acid resistant than H. pylori is. Although H. pylori has this reputation for living in acid because it does, that doesn't necessarily mean it thrives in acid. It just makes this environment okay. And part of that is moving into Candida cells. And so that Candida can help the H. pylori survive. They can work together. Their virulence works together. They can evade the immune system together. And it is very cute. So when it comes to treating H. pylori and Candida, frequently I will treat them at the same time. When I'm using pharmaceuticals, I don't always because it is fairly heavy hitting. But if I were to choose, and this isn't everybody's approach, but I choose to treat the Candida first. And now here's just a slide showing a research article about Candida as a trigger for celiac disease, showing that we've got that molecular mimicry. So those proteins on Candida cell walls are going to have that molecular mimicry or cross reaction with our alpha gliadin and gamma gliadin. And then the TTG, so when you test for celiac disease, you're looking at your serum tissue transglutaminase, and that can also be involved with yeast. So yes, yeast can be a potent trigger in celiac disease. Now, Candida and the epithelial cells in the gut barrier. So this is something that whenever I see Candida clinically, I will do gut repair. No matter what the zonulin says, no matter what the other signs are, if there has been a high Candida population, I assume that there is some degree of epithelial cell damage or distress. And that's my clinical approach. It might not be everybody's. Here's a beautiful picture from a research paper that was very well done, so that you've got your adherents here, and then your different methods of invasion. So you've got your transcellular and your paracellular. So transcellular means going right into the cell, and you're going to have the induced endocytosis, where the cell just kind of gobbles up the Candida. And then there's active penetration, and this is where the hyphae come into play, and they just stab right into that epithelial cell. Now here's your paracellular going between the cells. And there was actually a good study showing that there can be active penetration without actually damaging the cells. It just takes the cell membrane with it, at least transiently, doesn't have to create damage. Over time, I believe it actually would cause some damage, but in the short run, not always damage, but you do see a lot of cellular damage when Candida is present. Okay, so bottom line of that is when you see Candida, repair the gut after, no matter what. Now, briefly on Candida and the immune system, this might not interest everybody, but let's do it anyway. So neutrophils are the first line of defense against Candida. They're gonna trigger that pro-inflammatory reaction. So if you see a Candida that's more acute, you may see high calprotectin. So calprotectin is the protein that's pumped out by neutrophils when they migrate into the lumen of the gut. So on GI map, you'll see your calprotectin on page 4 in the intestinal health. It can be reasonable to look at a higher calprotectin, look at a Candida and think, I wonder if that might go down if we treat that Candida. Maybe, maybe not. It's always worth looking at your red flag findings and taking them very seriously, but that calprotectin can be high because of the Candida. Now, secretory IgA will control your Candida population, making sure it doesn't get to that virulent invasive state, which relies on healthy B cell function, healthy epithelial cells, nutrient repletion, gut lining integrity, a lot going into secretory IgA patency, and also a healthy normal flora. So on GIMAP, we're also looking at secretory IgA levels. So if you see high Candida and low secretory IgA levels, you're going to want to support that immune system in the short run while you treat the Candida to get it out. We're going to see some immune evasion, which means that Candida can trick the immune system. It can mask things like beta-glucans that would be inflammatory triggers. And in a couple of papers, it actually showed more evasion with higher population density. So sneaky Candida can kind of dampen down your immune system so that it leads to a more chronic infection or more chronic population, low-grade inflammation, not high-grade inflammation. And then it can induce that Th17 immune response, which can lead to things like autoimmunity. But the Th17 immune response can actually be protective against C. diff. I don't think we should advise our patients to pick up a Candida population to knock out their C. diff, but it's interesting when you see these immune interplays between organisms. And I think it's cool. So moving on to more clinical stuff, I'm going to show you what Candida looks like on GI map. So this is the test we offer, the stool test we offer through Diagnostic Solutions Lab. And now Candida here you see under the fungi yeast, this is on page 3 of the test, about 2/3 of the way down. So we've got our Candida SPP and then we've got our Candida albicans. And the difference here is when you see an SPP anywhere on GI map, here you see them for the other fungi as well, that's a placeholder for all the species name. And that means that we're looking at the genus level. So genus species is how it goes at the end of our taxonomy. And so this is all Candida except for albicans. And then we also want to look at albicans separately. On GI map, in my clinical experience, it's a lot more common to see Candida genus than just the albicans. Very uncommon to see albicans by itself. and reasonably common to see them both together. So here we see both are high. We see this high E4 level. And when we're reading the test, we want to look at the number to the right of the E, and that's our exponent. So that means that we're in the tens of thousands per gram of stool, where the range goes to the thousands. So range goes to 5,000, we're at 97,000. So that's a big, big population. And then the Candida albicans, just out of range, but less common to see. Candida albicans is one of the most common species we'll see in the human gut, but is not the most resistant. So when we see both, we're treating. We're given a good hearty treatment plan because Candida is a very resistant, very resilient organism. So moving on to another test where this is a bit of an older test, you see Candida is within the reference range. So it's here at the E2 level, the range goes to the E3 level. And I would still consider treating this if the symptom picture matched. So here we don't have Candida albicans present, we're less than detection limit, but we do have the genus. So if there were any indications that this person had a fungal overgrowth, I would be treating this. And generally at the E2 level, I will be strongly considering treatment. The lower you go in the level, the less likely I would be to treat it. But if symptoms are severe, sometimes I still will, because Candida, being an upper middle GI tract organism, you might not see the full extent of it in the stool that might be present in the upper GI. So I'm considering any population of Candida that I see on the test and considering it for treatment. I'm not treating every single time, but I'm thinking about it. So that's how I approach interpretation of the GI map Candida. Now onto diet. So I'm going to talk about treatment with antifungals, antimicrobials, things like that in a little bit, but Candida diet is a huge deal. And in my clinical opinion, I think we're often overdoing it on our dietary recommendations. This is a diet that should be in place as a long-term lifestyle, and we should keep it simple. So general principles would be following a whole foods diet, plant forward. So most of your diet's going to be plants, have some well-selected protein, and then spacing your meals so you have that chance for the Candida to not be fed. Drinking lots and lots of water, keep it simple and manageable. And those are my general principles. I'll get more specific in the following slides. So what to avoid? I think we're avoiding too many foods in the Candida diet. I think we're going overboard. We need this to be applicable to our patients, and then some patients will need a very strict diet. So you'll have to play it, play it depending on the patient, but I like to start by avoiding processed carbohydrates. You're avoiding your sugar sources, your white flours, your white gluten-free substitutes, things like that. I allow my patients to have whole grains, a bit of quinoa, things like that. Don't eat a whole pile of it, but have a little bit. I think it's okay for most people, and that fiber is really beneficial. So avoiding excessive fruit, like your tropical fruits, things like grapes that are really, really high sugar. And then high mold foods and alcohol. So those things are out for my patients. Things like mushrooms, I include in my Candida diet because there is some research out there showing that white button mushrooms have anti-Candida activity in vitro. So I don't see the rationale in avoiding mushrooms. If someone wants to come at me for that, I welcome it. But I let my patients have mushrooms and I encourage it. So here's what you want to eat: lots of veggies, lots of leafy greens, lots of cruciferous veggies, lots of nice healthy fats, things like avocados, lots of fermented foods. I like my patients to have fermented foods daily. So fermented dairy has been shown to actually inhibit some of the toxic byproducts of Candida, things like lactate dehydrogenase, I believe, is something that's inhibited by fermented dairy. I love the fermented cabbages. That's my personal favorite. Lots of healthy fats and well-sourced protein. So your nice clean protein sources. Even though Candida can feed on nitrogens, you want to keep the protein in the diet. So eat moderately. If your patients are doing okay, I think they can have a little bit of fruit. I love berries here. You've got some nice polyphenols that can be antimicrobial, anti-Candida, and can promote your nice, healthy, normal flora. Whole grains, like I said before, I do allow my patients to have moderate amounts of whole grains. So this is a moderate diet. Any diet I'm introducing is going to be, lots of veggies and then other things in moderation. So some starchy, higher fiber vegetables, things like your squashes, beets, carrots, most people should be able to handle those. Parsnips, I'd say, you know, potatoes, maybe, maybe not. Sweet potatoes, I usually let my patients have some of those and see how it goes. And then treatment. So this is going to be a bit of a section, and then I'm going to go into a case. So pharmaceutical treatments available. You may or may not be a prescriber. You can treat Candida with or without pharmaceuticals. And that's important to know. So the most common things we're going to see are nystatin. You're going to see amphotericin B, and then you'll see your azole derivatives. That's like your itraconazole, your ketoconazole, fluconazole, clotrimazole. And so we're seeing more efficacy with the nystatin and the amphotericin B, a little bit less with the azoles, although they're still very popular, still very effective. Things to know is that the nystatin and amphotericin B do have pretty decent anti-biofilm activity. In practice, I would probably still introduce more biofilm disruption, but you can see a little bit with these pharmaceuticals. And then when you are prescribing pharmaceuticals and you want to augment them with natural treatments, look into your research, and you want to look and see if there's any research with that pharmaceutical and that supplement, because a lot of our natural treatments can augment our pharmaceutical treatments. And in the papers, you're looking for keywords like additive effects, which means that nystatin plus berberine is better than nystatin alone. Indifference would mean that nystatin plus berberine is no better than nystatin by itself, just for an example. So additive and indifferent, that's fine. Indifferent, I'd say, why bother? But you know, sometimes studies don't look at every aspect of a botanical. Synergistic is where you really get into great things, where the total effect of nystatin plus the total effect of berberine, if you put them together and use them together, you actually get a greater effect than the two added together. But what you want to avoid is the inhibitory effect. So for example, if you are using amphotericin B and then you give Saccharomyces boulardii, which is a really, really common anti-candida supplement and probiotic, it actually is inhibiting the activity of amphotericin B. It's got that capric acid output, which itself is anti-candida, but it also inhibits that medication. So if you are going to be using those, use them wisely, look into the research, and see what you can find. Okay, so moving on, we're going to look at our botanicals. I've got some of my favorites right here. These do all have research-based, usually in vitro studies. I believe for all of them, they're in vitro, might be some in vivo, but when it comes to botanicals, you don't get as good quality research as you do with pharmaceuticals. Most of your research is in vitro, and then you see your clinical experience. And there are some that work really well in my clinical experience and in the experience of others. And this is the hot list of things to use. I would say oregano, thyme, limonene. I love lemongrass. And green tea. I think green tea is just so easy to add into a protocol that I use a lot of that. I like our botanical combinations that we can get, often combined with nutraceuticals. So lean into those botanicals. They work really, really well. Most of these have things like biofilm, anti-biofilm activity. They may be affecting the cell wall. They may be affecting organelle function. They may be affecting, you know, DNA production, things like that, or DNA structure, and inhibiting enzymes, inhibiting efflux pumps. You've got a lot of activity here. Oh, and then you may want to add in things like adhesion inhibitors. And a lot of these botanicals like green tea, garlic, I believe, and licorice are strong adhesion inhibitors. So you've got a lot within these whole plant herbs. So not just the standardized extract, but the whole plant. So you're going to have a lot of different activity that will be anti-candida. So in my mind, it is very rational to mix your pharmaceuticals with botanicals and with your nutraceuticals when you're going to be using pharmaceuticals. Just make sure they're not inhibiting each other, or use them at different periods in time. So your nutraceuticals, this is not an exhaustive list, nor were the botanicals, but some of my favorites are sulforaphane, and these have in vitro anti-candida activity, and resveratrol. And of course, you can get your sulforaphane and your resveratrol from the diet. You know, back to grapes, when I said don't eat a ton of grapes, you know, red grapes might not be terrible, but they are very high sugar. So I generally do avoid them. Red wine off the menu. Propolis is great. Caprylic acid and undesolenic acid, different sources, both very strongly anti-candida. And then fiber. I love using fiber in my protocols. It's going to boost your normal flora. It's going to help bind and eliminate toxins. It's going to be doing all sorts of great things for your colonic cells. And then bentonite clay I often toss in my protocols as well. So gut environment support, when you are treating an organism that can adapt to any environment, you just want to make that environment as healthy as possible. So you want to use things like probiotics, prebiotics. So the probiotics that I use the most and that I think have the best research backing them are going to be your lactobacillus strains. So things like Reuteri have been very well studied to be anti-Candida. Saccharomyces boulardii is very effective in your protocols unless you're using amphotericin B. Then hold off on that until later, or maybe dose them at different times in the day. Your prebiotics are going to be great. You could even use some postbiotics. So when it comes to using probiotics and working on the normal flora, it's actually the postbiotics or the bacterial products that are going to be your natural anti-Candida agents. Then polyphenols, you can get these through diet. If you're having a nice, healthy, whole foods, brightly and darkly colored diet, you're going to get a ton of polyphenols. You're going to get a ton of fiber. And then you can also supplement these with some nice gut-directed polyphenol supplements. And then gut repair. Always when Candida is present, we're doing gut repair. Sometimes I start it right off the bat when I start treating Candida. Usually I do. And sometimes, rarely, I'll start it after I've done the antimicrobial phase. And then you want to support your digestion. So making sure that all the nutrients you're taking in are getting broken down, getting absorbed into you, and not getting left behind as food for your Candida, for your bacteria, for the other organisms that may be hanging out in your upper GI just waiting for that opportunity. So I'm using digestive enzymes, brush border enzymes, usually in combination with your pancreatic enzymes, but they're very different. Ox bile, often I'll use HCl as well. Now, treatment considerations. I think this is a very important concept. This in the next slide. I generally treat for 2 to 3 months, and when I speak with practitioners, that 8-week protocol, 8 to 12 weeks with a lot of bacteria, things like that, it's going to be 8 weeks, but Candida can be a little bit stickier. So 2 to 3 months is what you'd expect for strictly the antimicrobial portion of your treatment plan. You want to wait 1 month after antimicrobials and then retest and see what you're looking at. Continue the diet after you're done your antimicrobials for a good 3 months beyond treatment, and continue your gut repair protocols 3 months beyond treatment. And they've shown in at least one research study that the eradication rate after an antimicrobial protocol in 2 groups were about equal, and then 3 months down the road, it was about double in the people that were following the lower carb diet versus people that just went back to their regular diet. So there was a big reinoculation or repopulation of Candida in people that went right back to eating their higher carb, more processed diets. So consider adding to your protocol some biofilm disruption, liver support, and digestive support. I add digestive support and biofilm support to every protocol, and very frequently I'll add in liver support, and then immune support as needed. So order of treatment. Here's what I generally do when I'm approaching a treatment plan, and we'll look at a sample treatment plan with our case today too. So I support any systems that need support. So adrenals, thyroid, digestion, liver, things like that. We'll support those first for a couple of weeks. And if we have a very, fiery, severe Candida case, maybe we want to move in quicker with the antimicrobials. But in a case where it's low grade gas and bloating, brain fog, low energy, I would want to get in there and do some support first. And then we move in with the antimicrobials, and there's a lot of overlap between the order of treatment. This is not just your 4 or 5 hour protocol. We can mix the R's all together. And then we support and reinoculate your commensals, and that I do actually during the antimicrobial phase, even before the antimicrobial phase a lot of the time, but we want to put in a very strong effort during and after the antimicrobials to get those normal flora back functioning. And we're going to really support those with gut repair. So the gut repair with Candida, I think I've driven that point home enough. Hopefully, if there's Candida, repair that gut and do it for a good 3 months after you finish your kill phase. So what to kill first? And this is going to be debatable. I'm going to get some heat for this from some practitioners. Bring it on. So I think this is highly variable. So there's the top-down approach, and a lot of people are very sticky with their top-down approach, where if there's H. pylori or something in the upper GI, you need to treat that because it affects everything else and sets up the environment for the other organisms. And I don't disagree. The times that I will leave the top-down approach behind is if you have a case that is, there's a bit of H. pylori, you think it's going to be relevant, but somebody is absolutely just burning up with Candida or burning up with Giardia, and you think they would be overwhelmed by treating both at the same time. I would say, let's relieve some symptoms. Let's get our patient feeling good about our approach, get them on board, feeling better, thriving their life, because when you have gut organisms, when you have heavy dysbiosis, your patients are going to come in with a lot of overwhelm generally in their life. And so the simpler you can make their protocol, the better. The quicker you can cut through that brain fog, the quicker their overwhelm will dissipate and they'll be able to handle your more complicated protocols. So then you can layer in your H. pylori treatment and your everything treatment, because our gut treatments, they can get quite heavy. Often we're doing short-term, a lot of products. So that top-down approach is great. I do support it, and it's just not always the order that I follow in my practice. And also going back to the concept of Candida and H. pylori cohabiting, often I'll want to kill off that Candida before I kill the H. pylori just to see what all was in there. If you can have H. pylori inside your Candida, kill the Candida. So looking at the root cause. So sometimes an overgrowth of H. pylori, again, this is similar to the top-down approach, but H. pylori can affect the Candida population by setting up that environment that it thrives in. But something like Giardia can set up the small intestine environment so that you've got impaired absorption and digestion and absorption of nutrients. You've got inflammation. All of that environment is an environment that other organisms thrive in. So if I see Giardia and someone's got that history of everything was worse since, drinking stream water or something, and it just really sounds like a Giardia case, I might kill the Giardia first, because I think that can really set up a lot of dysbiosis in the gut. So this is going to be multifactorial. Basically, it's not a black and white list of, first parasites, then H. pylori, then Candida. It's going to be a patient by patient basis. And that's what makes it fun. So we're looking at the dominant symptoms again. So if somebody is highly symptomatic with Proteus, you treat that Proteus right off the bat, or at least I treat the Proteus right off the bat. So that's my personal approach. And then symbionts. So thinking about the organisms that live well together and maybe in biofilm together and working together back and forth. If I can, I'll treat them all at the same time. So that's my approach to killing order. It didn't simplify your life, and that's okay. Life doesn't have to be simple. And then again, we're thinking about the spectrum of your botanical activity, and that means that when we're using botanicals, often our herbs are extremely broad spectrum. So while you are thinking about, okay, first I'm going to kill Candida, and then I'm going to kill Dientamoeba fragilis, and then I'm going to kill H. pylori, know that a lot of our botanicals can target all three at the same time. So something like black cumin seed or wormwood, you're going to have some action against all three, at least in vitro in research. So knowing that our botanicals aren't always as specific as things like our prescription antimicrobials or antifungals, antibacterials. Okay. So on to our case. We've got ourselves a 39-year-old, and gas and bloating was the main concern. And you can see from the picture, this is not actually the patient. Obviously, we've got constipation, reflux, and upper GI pain. So a lot going on GI-wise. These symptoms could be anything in the GI. So testing is really, really important. We've got sugar cravings, which makes us think, yeah, maybe Candida, maybe Pseudomonas. A lot of our bacteria can also lead to sugar cravings. Lots of food sensitivities, and then frequent vaginal yeast infections. So when I see a case like this, I think, yeah, there might be some yeast involved there. Very likely to be some yeast involved, and we may see Candida on a test. If we don't see Candida on a test, maybe we'll see it on an IgG serum test, and maybe that would make it relevant, because in the gut, if it's in the stool, it will show up. GI-MAP detects it down to a very, very low level, and then Candida is an organism that is very evasive, and even when it's in the gut, it might not show up in the stool. And I don't think that makes it rational to treat Candida that you haven't found, because it will it will very frequently show up, and the amount that it shows up in our data sets are, really matches the epidemiological research and how much it should be showing up. So it shows up exactly the right amount, but then in some cases, it's a sneaky organism. So wherever you find it, treat it, and then know that things like your IgG antibodies can persist for months and months. So if you've treated it, you don't want to retest using an IgG. And that's all I have to say there. So this is the case, and we're going to look at the test. And because this is a Candida webinar, I'm going to start with Candida, although this is on page 3 of the test. I just didn't want to keep you waiting to find out, will there be Candida? Yes, there's Candida at a very high level. So we've got an E5 level Candida compared to our E3 reference range. We're just over 100 times the reference range there. So we're in our hundreds of thousands per gram of stool. In my practice, I start treating generally in the E2 level. So this is really, really high. When you look at our data plots, this is actually, above the curve. This is a lot of Candida, definitely treatment worthy. And whether you use pharmaceuticals or botanicals, I think you can do either. Just treat it. I don't want to say aggressively. I would say treat it intensively. You want to get rid of this Candida. Now, moving through the test, I haven't shown everything on the test, just little snapshots of where we see relevance. We're looking at page 1 here at our pathogens, and Giardia is present. It's within range. It's in the thousands per gram of stool. So in a case like this, maybe it's relevant. We will see, in my practice, generally it would be when I see multiple dysbiotic overgrowth, I'm going to be addressing them, and I'm also going to be addressing immunity and digestive function and all the things that can lead to multi-organism overgrowth. On page 2 here, we see H. pylori, and it's also within range. It's at the E2 level. Our range goes to 1 E3, and so this is 1,000. 1 E3 means 1,000. 9.78 E2 is 978 organisms per gram of stool. That is very close to the range. So it is not yet statistically significant, but in a case with strong reflux, upper GI gas and bloating, I'm going to say this is likely to be somewhat significant, and I would consider it as part of the protocol either now or later. I think now would be rational depending on how much you're going to need to add into your protocol. So we're considering H. pylori. Looking at our commensals, these are the organisms we want to see. I start by looking at the phyla, and here we're looking at the population level. So the 2 phyla of Bacteroidetes and Firmicutes, this is the next level down from kingdom. This shows us the population level and should represent roughly 90 to 95% of our total bacterial population. And both are within an order of magnitude of the reference range, but they're both overgrown. So we've got a lot of bacteria. We're in a state of overgrowth here. We're not in a state of deficiency. Looking at the genus and species level up here, these are the organisms that you want to see present that mean something when they're high and when they're low. So it's not just, what organism is high, okay, let's kill it. It's what is that organism a marker for? We've got our surrogate markers that something like Akkermansia muciniphila, when it's high, we might be looking at irritation at the gut lining, excess mucus production, things like that. So here we see true overgrowth of our Enterococcus and our Akkermansia. We may be looking at irritation at the gut lining. We may be looking at a great little symbiotic relationship between Enterococcus and Candida. They have a strong interrelation where they can favor each other. And this is a lot of Enterococcus. It's likely to be more upper GI, likely to contribute to some gas and bloating, as are these overgrown phyla. And so that's what I see in the normal flora. And then we move on to the next page, which is our opportunistic microbes. So we start with bacteria and 1 archaea, and we see a lot of overgrowth here. So even more Enterococcus. It's Enterococcus faecalis that has the really strong relationship with Candida albicans. It's not present, but Enterococcus faecium is at a very high level, E7 compared to E4. We've got a lot of bacillus. We've got a decent amount of strep, a lot of Methanobacteriaceae. So we've got some gas production here. We've got Klebsiella, and that is a high growth at the E5 level. We're likely to be seeing some symptoms here. So this is not strictly a Candida case, but Candida is likely to be contributing to a lot of other dysbiosis, as is Giardia. So we see a lot. This is a heavy case. We've also got Fusobacterium out of range, which is one of our more inflammatory organisms. And what I see when I look at things like Klebsiella and Fusobacterium is potentially poorly digested proteins. So both these organisms can thrive on proteins. And so that's something that I might be suspecting maybe secondary to the Giardia. So we've got a lot to address in this case. Looking at intestinal health markers, not too much flashing red here, but there are a few things like the steatocrit here, that's going to be the fat in the stool. We're at 11%. This is 11% of the total stool volume. And that's a lot. In my practice, that's too much, and I think my patients can be doing better. So we've got a bit of a fat absorption or digestion issue. Maybe it's a gallbladder issue, maybe it's not, or a bile production issue. And then our elastase, our pancreatic function, looks just fine. Now we saw some markers that may indicate low protein digestion, and we see this high zonulin. So this is a marker for intestinal hyperpermeability. Not surprising when we see Candida present, not surprising when we see Giardia present. Klebsiella, which is a histamine producer, can increase this. So we've got our leaky gut here. And when we see this compromise of the gut lining, what I often supplement for digestive support is a brush border enzyme. And that's going to break down those dipeptides into single peptides that are available for absorption. So sometimes you're missing those brush border enzymes when the gut lining is compromised, and that's where I would supplement. I would probably, think about giving some HCl depending what my plan was with the H. pylori. I would give some fat absorption support. And that can be as simple as chewing your food better, taking bitters, relaxing around meals. So see where there's room for the lifestyle approach. Now, other things, just one more thing I see here that could be optimized would be the secretory IgA, because we know the secretory IgA is important for the clearance and reduction of virulence in Candida. And this is just within range. 510 is the bottom of our range. I'd like to see this at least 800 for good, strong immune function. So I would likely be supplementing some immune support in the short run. Saccharomyces can be great for this. I use a lot of bovine immunoglobulins. Colostrum can be helpful. And then in the longer run, we're repairing that gut lining and working on nutrition, working on the normal flora, and I would expect this to come up with an improved gut environment. So that's what we see on the test. And then there's another test result available for this patient. It's called the Omics. This is one of our newer tests through Diagnostic Solutions. It's an amazing urine and plasma test that is measuring your whole metabolism. And we've got this page here on microbial metabolites. So in a test like this, if you just ran the omics and you see something like this on our microbial metabolites page where you're just lighting up the indole acetic acid, you're seeing the dihydroxybenzoic acid, you're seeing the hippuric acid equals high. I'm not too worried about that. But then your arabinitol is on the higher end here. So that D-arabinitol is one of our yeast markers. It is non-specific for Candida. So if all you saw was an arabinitol, it would not be fair game to treat Candida. You need to see other signs. You need to find Candida somehow. But seeing it high and seeing the GI map also and seeing all these other microbial metabolites high, I'm thinking if this was all I had to look at, I would think, we're running a GI map. I want to see what kind of dysbiosis we're looking at. So this is what this page can tell us, is that, yeah, there's something going on here. Let's deal with it. And the GI map agrees because we have both tests. We've got a luxury there. Now, in a case like this, I love to just break down the most important findings, and that helps me simplify the case. So what I do is, in order of relevance, I'm going to break this test down. So we see Candida, a big overgrowth of Candida. And I know I've talked a bit about Giardia maybe being causative in some of our dysbiosis and some of our digestive issues, but the Giardia, compared to the Candida, the volume of the Giardia is much less of an anomaly. The Candida was a huge level. The Giardia was, we see that very frequently, and it is a common pathogen and it commonly affects people, but this is a lot of Candida. And the symptoms were very heavy for Candida. So the other organisms, because this is a multi-organism dysbiosis case, we've got our Giardia, our H. pylori, Enterococcus, Methanobacteriaceae, Klebsiella, Fusobacterium. So I like to write them all down, and then when I'm choosing my botanicals, I like to find some nice broad spectrum so we can hit all of them. And then digestive insufficiency. So we're looking at steatocrit that's borderline high. We're looking at maybe a protein malabsorption. So we're thinking maybe HCl, maybe not. When I'm actively treating H. pylori, I don't generally give HCl, but then a lot of practitioners do, and they do just fine. So if you're giving a normal physiologic amount, I think that's okay. We need some protein digestive support, which is what HCl can help with. And then I would be giving brush border support because we've got that compromise in the gut lining. We've got the signs of protein malabsorption. So suboptimal innate immunity, which means we were in range for a secretory IgA, but just not great. We can do better. And if we're looking to clear multiple organisms, we want that immune system to be active. We want it to be scavenging, recognizing and eliminating our organisms, not just our pathogens, our opportunists as well. And then we see that intestinal hyperpermeability. We would have treated this anyway without the zonulin, but we saw the zonulin, which is a nice icing on the cake finding, really makes a nice tidy picture. So looking at this case, we're going to look at an example protocol. So here's something that I would do, and I think it's okay in your gut-based practice to have a heavy protocol because we want to be effective. We want to get our patients feeling better. Usually they're in our practice because they're feeling very unwell because they haven't found anything that works. So if they're concerned, and a lot of people are concerned with overwhelm, you can take it a bit slower, but you're going to get the best effects if you treat everything. And it doesn't have to be everything all at once. So we're looking at lifestyle here. So I want this person to sleep by 11. They're going to get a nice night's sleep. That's going to augment your immunity, your digestive capacity. Your organisms do have a circadian rhythm. And so that's really important. Your ability to digest foods has a circadian rhythm. And so you want to get your foods digested nicely. Get to bed. Don't eat right before bed. You want to take your healthy lactobacilli before bed and your gut repair powders, things like that. So getting to sleep nice and early. We want to increase water, 2 to 3 meals daily, no snacks in between. We want to have that nice fast overnight, a little bit of a fast between meals. Chew your food really well. Take breaths before you eat. So all this food hygiene stuff, so important. And avoiding alcohol, avoiding stress as much as possible as well, which I don't believe I wrote down here. And then diet. Super simple. There are the slides on diet, but really just a nice, healthy whole foods diet. So knocking out those processed carbs, sugars, grains. We want to increase our veggies, including mushrooms, eat fermented foods daily, protein with every meal, berries daily is in my protocol. Sometimes people can't handle it. Most of the time they absolutely can. And then a cup of green tea daily, at least one, is a great adhesion inhibitor. It does a lot of things, nice antioxidants. It does pretty much everything. So why not have some green tea in your protocol? So moving on to our supportive supplements. So I do generally like to start with supportive supplements. And in a case like this that had fairly low grade symptoms, you can start with this stuff. So you get the diet in place, you get the lifestyle in place. It's amazing what you can get, what kind of results you can get just by getting people to drink water, chew their food, and relax, and maybe eat a bit more protein. Those things are going to be amazing. So we're going to add in a digestive enzyme. We're going to add in an immunoglobulin to support that immunity. I like sulforaphane. We can do this with broccoli sprouts if we want to toss this in diet instead, but I do love it as a supplement. And I'm going to put in a gut repair powder. I have my favorites. I'm not going to list them here, but there are some amazing gut repair powders. And then sometimes when you add them too early, they can cause people to bloat. So you may want to choose a non-fermenting gut repair powder right off the bat. And sometimes people will be fine. So you kind of ask them about their fiber intake and how that affects their bloating. If you have a very bloaty person, if they say, oh, I can't handle any vegetables, I can't handle any fiber, maybe you're going to go with something non-fermentable. And then fiber, same story. Don't hurt your patient, but fiber can be very beneficial. And then we want to add in our protective organisms. So I like to add in S. boulardii and a lactobifidobronc. I'm usually using about 50 billion throughout treatment and then for a good couple of weeks after. And then the antimicrobials I would choose in this case for these organisms. I won't get deep into this, but this is the list I would use that I think has some great cross action between the organisms. I've chosen to leave out things like mastica and black cumin seed. In this case, I wouldn't go heavy against that H. pylori. I'm going to treat just general dysbiosis and then come back and see where it is. A lot of these botanicals have in vitro activity against H. pylori. So I don't have a problem with treating like this. If you like to treat H. pylori as part of your first protocol, you'll add in things like your mastica and your black cumin seed right off the bat. And then after we're done the antimicrobials, so that is a 2 to 3 month protocol with the antimicrobials, at least in my practice. And then we want to continue the diet for an extra 3 months. We want to continue the gut repair for 3 months and really ramp up that gut repair after you're done the antimicrobials. So that's when, if you weren't using a fermenting gut repair powder, which is usually the really good ones, have kind of some fermentable things like your okra and your pectins and things like that. I like to add in butyrate. Again, that gut repair powder, you might change that at this point. Tons of probiotics, fish oil, and it goes beyond this as well. You've got your lifestyle, so sleep, rest, hydration, keep the alcohol out as much as possible. And we're really wanting to support our normal flora here. We want to support the environment. We want to keep our digestive support in there as needed. So within this 3-month period, after 1 month of finishing the antimicrobials, you can retest. So that's a great time to retest to see if you have eliminated some organisms, see if different ones have taken their place, because often on retest, you don't see what you expect to see. So it is really valuable to see that, especially if your patient is not feeling absolutely perfect and wonderful. Sometimes they will, sometimes they won't. So 1 month after antimicrobials is when you retest. You can have all your diet, your gut repair in place while you are testing. So that's it for my case, just a quick summary, and then I will be done. I've almost used up our whole time. So Candida is a super resilient organism. It is going to defy you on every level. So treat it. You'll do well. Patients will feel great. Your clinical outcome is going to depend on a lot of factors. So your patient's immune system, the state of their microbiome, your protocol, the gut conditions, general health, antioxidant status, everything is going to have an effect on your clinical outcome, and it may take more than 1 round of protocol. You're often going to see your co-infections there, so treat them all. They don't all have to be treated at the same time, but make sure you address everything that comes along with it, and then the root causes. So is it a digestive insufficiency? Do we have motility issues? Is it an immune function issue? We want to find out why we have these co-infections, because they don't just pop up out of nowhere. They pop up because they can. That's what makes them opportunists. Treat with a nice strong protocol for at least 4 weeks. I'm usually using 8 to 12. If you're using your antifungal prescriptions, you can go a little lower. And then you want to continue that diet as an ongoing lifestyle. And so that's the end of my presentation. I am done talking for now, and I just wanted to thank you again before we get to the Q&A. Thank you for being here. We see you. It means a lot that you're here, and we are here to help. So we want to be easy to work with. We want to help you get great results for your patients. So we do have the clinical team. That's the medical education team that I'm part of. There are 13 of us. We can help you interpret your test. So if you look at the test and you think, this is great, but I have no idea what to do with it, we do this every single day, and we look at thousands and thousands of tests. So let us help you to get the best results, and use our customer service team, use our sales team, and we want you to do well in practice. So that's it. Thank you. Let us help you, and have a wonderful day. But I think we're gonna have some questions.
Amy, we do have a couple of questions on here.
Thanks, Heather.
In regards to diet, what do you recommend regarding fermented foods for a patient with histamine intolerance?
That's tricky. And so you can have histamine issues because of the Candida. So you might want to leave out fermented foods in those patients, and you might want to do a trial of them and see how it goes. You hear in your SIBO patients and histamine patients to never use fermented foods, and I find that some people do just fine and some people don't. So if there's somebody who's a little bit more flexible in their ability to tolerate things, and when you have your patients that are quite brittle and patients that are more flexible, try it a little bit in your more flexible patients, and they might do great and they might not do great. So I don't have my patients on a low histamine diet very frequently unless it's absolutely necessary. I usually take a different approach, and that is a topic for a different webinar. But so I like to dabble in things that are reported to be not good for our patients when I think they're good for general health. I think it's worth a try sometimes, but your patients that react to everything and have severe histamine issues, I'd leave out the fermented foods when in doubt.
All right, next one. If Candida triggers celiac disease, once it's treated, can the patient resume eating wheat, or is the celiac permanent?
The celiac is permanent. you're always going to have that recognition. So celiac is an always gluten-free type of situation, but like any autoimmune trigger, if you have a persistent infection of that organism, say you've got Klebsiella that's affecting an autoimmune joint issue, you will, I would say, always have that predisposition to autoimmunity, but you can reduce the severity. So you might have somebody with celiac disease that's just not getting symptom remission, even though they've been strictly gluten-free. And then you remove the Candida and they feel better. So it's one of those things where when you remove the offending trigger, it may or may not have been the trigger even. It can just be something that can, push that branch of the immune system to make your autoimmune condition worse or your symptoms worse or make you more inflammatory. When you remove that immune burden, your symptoms will get better and you may go into remission. But remission in celiac disease, you're still going to be gluten-free strictly at a cellular level forever until somebody proves me wrong. I'm going with that.
Okay. What is the reason you do not give HCl when actively treating Candida?
Ooh, that's a deep question. So when you look at the research for antibiotics against, oh, did you see Candida? It's H. pylori that I avoid the use of HCl and not Candida. Did I hear that right? Anyway, when I'm treating H. pylori, I like to not add in extra HCl, and that is my own personal extrapolation from the research I've looked at, because when you look at antibiotic protocols with and without a PPI, a proton pump inhibitor, which modifies your stomach acid to make it less acidic, you see greater efficacy pretty much across the board. And that is true for things like clarithromycin, and that's an antibiotic that is more effective at neutral pH. So natural that a PPI would increase the effectiveness, but when you look at something like quadruple therapy with metronidazole, it's also more effective. And so when you look at amoxicillin, I think it's pretty ambivalent might not be the right word, but it doesn't really matter what the pH is for amoxicillin, but for metronidazole, it's actually more effective in higher acidity, and yet you see greater efficacy of the protocol when you neutralize the stomach acid. And what they've shown is that the penetration of the mucosa with the antibiotic is actually better when you have that more neutral pH. It makes that mucosal layer less viscous, less viscous, looser. And so you can get that drug deeper into the tissue. And so to me, it's not exactly the same, but when we're using our natural treatments, I want to get them into the H. pylori. So if you're actually actively treating the H. pylori, and it is a mucosal organism, so it lives in the crypts of the stomach beneath the mucosa, to me it's rational that you want to get your contact antimicrobials right in there if you can, and it can be hard to do, another evasive organism. So the more you can penetrate that mucosal layer with your antimicrobials, and sometimes I'll even use our intracellular antimicrobials, the better in my mind. And so don't add more acid because it makes the mucin layer or the mucosal layer more viscous. And that's my answer. And then another answer is that I see practitioners doing that all the time. And that's kind of the going thing to do, is avoid HCl when you're actively treating H. pylori. Yeah, so that's my short-ish answer on that.
All right. Well, that pretty much wraps up all of our time for today. Thank you so much for your time. And we'd like to thank everyone for attending today's webinar.
Thanks, Heather.